Good evening. Thank you for joining us for tonight's webinar, Break Free from Pelvic Floor Disorders, presented by Michigan Medicine's Von Voigtlander Women's Hospital. We'll wait just one more minute and then we'll get started. Good evening again. My name is Allie Novara, and here with me this evening is Shirley Loy. We will be the moderators for tonight's event. There are a few things I'd like to mention before we get started. If you run into any issues during the webinar, please use the chat function to let us know what is going on. Make sure you click Moderator Chat to chat privately with myself or Shirley. After the presentation portion of the event, you will have an opportunity to ask questions. Questions can be submitted using the Q&A box. Click on the Q&A button, type out your question, and click Post. If you join the webinar as a guest, your question will be anonymous. However, if you join the webinar using your email address will post along with the question and can be seen by other participants. At the conclusion of the event, you will receive an email with a link to a recording of the webinar, as well as a link to a survey. Our presenters this evening are a few of our wonderful clinicians from the Pelvic Floor Disorders program. We have with us tonight Dr. Dan Morgan, Dr. Megan Schimpf, physical therapist Jen Schiffert, and Dr. Carolyn Swenson. The Pelvic Floor Disorders program also includes Drs. John Delancey and Dr. Dee Fenner. In addition, Dr. Pam Fairchild will be joining the program soon. You can schedule an appointment with one of our providers at the new West Ann Arbor Health Center, Parkland Plaza, at the Von Voigtlander Women's Clinic, or the Northville Health Center. In addition, Michigan Medicine offers the Healthy Healing After Delivery program that provides support to women with postpartum specific ailments. Let's begin the presentation.
Thanks, Allie. This is Dr. Schimpf here to start our presentation with a quick overview. We're going to talk a little bit about the pelvic floor disorders that we see here in urogynecology, and a little bit about what is the pelvic floor, because that's the next question we usually hear. We're also going to talk a little bit about risk factors for pelvic floor disorders, why you have these problems, and then we're going to break out and talk specifically about pelvic organ prolapse and urinary incontinence in more detail. Jen Schiffert's going to go over some information about physical therapy, which is one great treatment option. And then we'll have our time for questions and answers at the end. And again, if you just kind of joined in a few minutes late, feel free to use that Q&A box on your screen at any time, and we're looking forward to answering those for you in a little while. So what is the pelvic floor? In this screen, it looks like a gray box. And in reality, it's a group of muscles that are situated at that location that help support and help function with the bladder, the vagina and uterus, and the bowels that pass through them. We do a lot of research into the pelvic floor here at Michigan, and so we know that there can be damage that happens to the pelvic floor throughout a woman's life, namely with pregnancy and childbirth, but also sometimes with other things that can happen, such as repetitive exercising or even through your job. Because the pelvic floor is interacting with all those different organs, problems with the pelvic floor often overlap between all those different areas. So these are some of the problems that we hear about from patients who have pelvic floor problems. So lots of patients talk to us about feeling a sense of pressure or a bulge inside the vagina. They talk about having urine leakage or incontinence where they can't control the urine before it starts coming out. Sometimes this is called an overactive bladder, when you have to go and you can't make it in time. Some women also have trouble emptying the bladder. Maybe those muscles are too tight and they don't let the bladder empty enough. Same problem can happen with the bowels, where people can be constipated and have trouble getting out all of the stool when they're trying to have a bowel movement. On the other hand, you can also have incontinence of those organs too, so gas and stool can leak out when we don't want to. We're not going to talk about that specifically tonight, but that's a problem that we treat as well. We know that that can be embarrassing and difficult to treat, and we're here to help you for that. So we have a whole program actually here that is designed to address accidental bowel leakage and other gastrointestinal overlapping problems. That's called the Michigan Bowel Control Program. We work with multiple different specialties in that area. Feel free to call us to set up that appointment as well. So there are three main types of pelvic floor disorders. The first one is actually not showing up there, but it's actually bladder control problems. And that's what we've just talked about, where urine can leak out when you don't want to. Sometimes when you're coughing or sneezing or exercising, maybe even just when you're yelling at your kids. But it also can happen at the most embarrassing times when you don't feel like you have to go to the bathroom, you don't think you need to bother going, but then all of a sudden it feels like you should have gone to the bathroom 10 minutes ago and the urine just starts coming out. The second problem, as you can see here, is called pelvic organ prolapse. That's where one or many of the pelvic floor organs, like the bladder, like the vagina, like the uterus, or even the intestines, can drop and cause the bladder wall to prolapse through the vaginal opening, causing a bulge at the vaginal opening. The other thing that can happen that we'll talk a little bit about are bowel control problems. We just mentioned some of these things can be very problematic for women and can be caused by a wide range of problems. It says 9% here on the slide, but we know that that number is probably a lot higher because this can be so embarrassing that we know a lot of women don't bring this up with their provider. So one of the goals of tonight is to let everybody know that these problems are common and that we can treat them with good new treatments. Sometimes we know that women have heard from their mothers or their aunts that perhaps they had a treatment 20 years ago that didn't work, and so why bother going? But there are lots of new exciting things that we're doing that are having much higher success rates than in the past, so don't let that scare you away. So these are some of the risk factors, and these are some of the things that you can control. Smoking can cause tissue damage. It can also cause chronic coughing, which makes these things more prevalent. Maintaining normal weight will help reduce incontinence. Being physically active, even if that's causing you some leakage, will help your overall body be more healthy, and that can help you maintain some of the health required for some of these treatments. Extreme sports can sometimes cause the symptoms to be more bothersome, so be cautious with them. But if you're noticing that you're not doing those things anymore because you leak urine or something else happens that bothers you, that's the time to speak up and try to get treatment. Lots of the problems that we see with the bladder sometimes relate to the amount of fluid that women drink. In our society today, we're all drinking coffee and Starbucks all the time, and we all think that we need to drink 8 glasses of water a day. Actually, there's no science behind that. So limiting caffeine, cutting back a little bit on what you're drinking can sometimes make things better. Constipation can actually make the bladder symptoms worse. So limiting constipation, limiting straining when you go to defecate can make these symptoms less bothersome. Just generally maintaining good health is also recommended. So keep your pelvic floor healthy, control your blood sugar, control your diabetes, and try to minimize coughing. If you have a cough, talk to your regular doctor about how to make that better. Some of these things on this side are not so controllable. So we are born with certain things, and then hopefully throughout life we age, and that sometimes incurs new things like menopause happens, pregnancy can happen, childbearing can happen, and that's going to increase the risk of this, but not necessarily for everyone. And then there are these other health conditions that we know can happen, sometimes outside of our control, and they can impact the prevalence of these conditions or maybe how bothersome they are. So before we start talking about the individual conditions, we just wanted to go over a little bit of anatomy. You can see on this slide that this is a basic slide of a woman's anatomy. So this is the front part of her at the left, and you can see the pubic bone is sitting right there. And then moving towards the right, we see the bladder, which is that kind of orangish organ sitting there. Next, moving towards the right would be the uterus, which is connected by the cervix to the vagina. And then all the way towards the back are the bowels. So the rectum, and then the anus is what we call the opening of the rectum. You can see from this picture that everything is very close, and that the organs, however, are inside this picture, are up inside the pelvis and not pressing on each other. So just a couple things about that anatomy. We store urine in the bladder. So there's a complicated drawing here that I don't think is worth going into in a lot of detail, except that it does show how complicated the bladder is in its workings. It works with the spinal column, it works with various centers in the brain, and the job of the bladder is to store the urine until it's time to go to the bathroom. And through a tube called the urethra, the urine comes out of the body. Muscles and nerves, both the pelvic floor and the nerves in the spinal canal and the brain, help control these two organs and the muscles that surround them. And then when you get that urge to go to the bathroom, everything sort of changes from the storage phase to the urinating phase, where different muscles squeeze and different muscles relax so that the urine can leave the bladder through the urethra. And we think it's also important to point out that these problems can happen to women of all ages and health. So this isn't just an old woman's problem. We see patients of all ages who are bothered by these problems, and we can help all of them at different stages of a woman's life. We do know that incontinence gets more common in older women and can be up to about 40% of women aged 80 and over. But still, 1 in 4 younger women who are under the age of 40 can feel various changes in the pelvis, whether that's prolapse, things dropping and bulging at the opening, or incontinence with running, like this woman's doing in this picture, or running to the bathroom. Women in the younger ages are more likely to be having children, and sometimes those changes right after delivery can cause leakage of urine or leakage of stool. That's why we have a whole clinic for women in the postpartum time. So some symptoms of urinary incontinence that we hear a lot about: the strong sudden urge just before the leakage happens that you can't control. Sometimes it's small amounts of urine, sometimes it's larger amounts of urine that come out with coughing, laughing, straining. Some women notice that the urine stream doesn't seem to be as even as it used to be, or it's weaker, and there's a sense that the bladder doesn't get empty when you go. And urinary incontinence can also happen during intercourse. So we see women that leak urine during intercourse. That can be very embarrassing to both the woman and her partner. So I'm going to introduce Dr. Dan Morgan now, who's going to go into the different kinds of incontinence in a little bit more detail.
Thank you, Megan. My name is Dan Morgan. Again, I'm a professor here in OBGYN and this area of medicine. And thanks for sharing your Cyber Monday with us. I realize it's a competing priority. So I was going to talk a little bit about the different types of symptoms: stress incontinence, urge incontinence, and then there are some other types of incontinence. But basically, the symptoms that we try to understand and are the most common are stress incontinence, which happens when you do something forceful, such as coughing, sneezing, laughing, lifting, or exercising is also very common. Urge incontinence is also known as overactive bladder, and that can happen frequently as well. It's the symptoms that are often well shown in commercials are the gotta go now that you may have seen, and with somebody rushing off to the bathroom. And when you have a combination of these symptoms, you may hear the term mixed incontinence. Continuous incontinence is a little less common. and it can really run the gamut of being somewhat predictable in that your symptoms are very frequent throughout the day, or completely unpredictable in that you're having difficulty identifying a certain activity just before that happens. So the important thing that we'd like to make sure you know is that there are good treatments available, and some of these things are going to be better for certain patients than others, and tailoring that treatment is going to be the most important. For most patients, trying to concentrate on some simple things first is very effective for many, and that can be a combination of things that are about your lifestyle, certain habits that you've gotten used to doing over the years. Sometimes minor modifications in those can be a big help. Often, to try to help identify some of those lifestyle changes, a bladder diary kept for 3 days can be extremely helpful. We do have a form, and it has a combination of different things that we'd like to follow. So while just following exactly when you void is one way of doing it before you come to see somebody, there might be a few other details that you'd be asked to do. And then Kegels or pelvic floor exercises are something that people commonly do. Often we notice that people do a little bit better when they're in a supervised program. And then there are some additional options that you see listed here, and we'll talk a little bit about each of these things. Often some combination of these things is necessary to help people try to get their best response. The different types of lifestyle things that certainly can be helpful. Exercise and weight loss can be very helpful for both stress and urge incontinence symptoms, as we talked about. Alcohol can certainly have a significant impact on people's ability to control symptoms, as well as bladder irritants. Caffeine is one of the bladder irritants that we often talk about, but some of the artificial sweeteners in different drinks can also be a significant irritant to people. And then just finally, total volume of fluid can be an issue. In general, we recommend that people drink to thirst, and certainly if you feel like you're pushing water or trying to do something that you think that drinking more and more, often we'll have people try to avoid that. And then finally, we also have people do the diary, as I mentioned, so that we can help you identify when things are happening and if there are certain triggers that are causing problems. And then sometimes we can do some strategies to try to help avoid the really unpredictable elements of incontinence. So for overactive bladder, there are some things that can certainly be done to help retrain your bladder. The bladder certainly does respond to our efforts to, if you go more frequently, then certainly your bladder becomes more and more used to emptying when it's at a lower volume. And so we can use that to our advantage, and to your advantage, by doing some different types of training. There is also, in a little bit, you'll hear from Jen Schiffert about physical therapy and different ways that you can use pelvic floor exercises to suppress urge, and often doing some kind of biofeedback with that can be quite helpful. And then finally, there are some medicines that if these things with lifestyle and physical therapy, things that are more simple and don't have side effects that medicines and other treatments do, we usually try to focus first on those things that are a little more more conservative. And then if not, those aren't successful, there's some good options. For overactive bladder, these are several of the new treatments that have become available. Some of them range from things that can be done in clinic all the way to surgery that's done in an operating room. So one of the most exciting treatments that is certainly available now more frequently is tibial nerve stimulation. We think of it as an acupuncture-like treatment that you come in for weekly for a period of 12 weeks, and it's been very successful in helping with overactive bladder symptoms by stimulating the nerves that go to the bladder. We can induce some response to decrease overactive bladder. Botox is something that you've probably heard about for other treatments. It helps to increase your bladder capacity so that you have less overactive bladder. And then finally, InterStim is a pacemaker-like treatment for the bladder that can help with increasing bladder capacity as well. Sometimes a combination of treatments is necessary. So just going back to those types of symptoms, we talked a little bit about urge incontinence, and we'll talk a little bit now about stress incontinence. So certainly one of the key pieces of trying to treat stress incontinence is physical therapy, and you'll hear a little bit more about this from Jen Schiffert, as I mentioned. It certainly can help with both stress and urge symptoms. Sometimes doing different regimens of exercise to strengthen are necessary, and then there are some things that you can learn that are a little bit more specific to trying to develop a skill to stop leakage at a certain time. One of the treatments that is done in clinic or can be arranged in clinic is use of a pessary. This is what we call a ring pessary with a knob on it, and the knob rests just underneath the urethra in the vagina. When it's fit well, women do not feel it in general. If it is something that does cause discomfort, then usually we try to get a different size or shape to be a better fit. And it can work quite well, especially for women who have symptoms with exercise-induced incontinence. So, and then finally, if you are still having trouble with those, or those treatments are not to your liking, there are several treatments for stress incontinence that are more procedure-based. There are urethral bulking agents. This is done in clinic or in the operating room. What is done is a small needle's passed through the lining to the urethra, and that material can help close the urethra slightly so that incontinence is less likely to occur with coughing, sneezing, laughing, etc. This is a lower success rate than some of the most common surgeries that you may have heard about, and I'll address that in a second, but it can make a significant improvement in quality of life with less risk too. The most common surgery for stress incontinence is what we call a mid-urethral sling, where a piece of mesh is placed underneath the urethra. And it's most commonly mesh, but it can also be from your body, a piece of tissue taken from your own body. It is performed usually in a procedure that takes about an hour in an outpatient surgery setting. It's been very well tolerated. We've been using this type of treatment for the past 15, 16 years and have had very high success rates with low complication rates. So there are two different types that you can see here, one that is placed behind the pubic bone, and then one that goes more laterally or to the side through the obturator membrane. So that is the overview of some of the treatments for urge and stress incontinence. And what I'll do now is turn things over to Dr. Carolyn Swenson, who's one of our partners.
Thank you, Dr. Morgan. Hopefully you guys are doing well and still staying with us. We're about halfway through, so I'm going to talk a little bit about pelvic organ prolapse, the types, the treatment options, and then pass it on to Jen Schiffert, who is going to give us some detail about pelvic floor physical therapy. So when we talk about prolapse, there are three main types of areas that the prolapse can occur. So like Dr. Schimpf talked about, the pelvic floor is comprised of a series of muscles that work to hold up your pelvic organs and hold them in place and keep them in the correct orientation. So there are three main compartments when we think about prolapse. There's the front wall or the anterior wall where the bladder lies, and that's what you can see in that picture on the left. So you can see the little arrow, that the arrow is actually within the bladder, and it's showing that the bladder is pushing in on the front wall of the vagina. So when this happens, this is called a cystocele. And again, that's prolapse in the anterior wall or the anterior compartment. The other place that prolapse can occur is on the back wall. And so in the second picture, in the middle picture, you can see that arrow, the black arrow pushing in, and that arrow is within the rectum. And you can see there's a little pouch pushing in on the back wall of the vagina. And when this happens, that's called posterior vaginal wall prolapse or rectocele. And the third compartment where you can find prolapse is at the top of the vagina or the uterus. So this is a pretty extreme example of uterine prolapse. So here you can see it's kind of hard to tell it's even a uterus, but you can see the uterus has come down right here and is prolapsing outside of the vaginal opening. So that's an example of uterine prolapse. Now, if you don't have a uterus, you can still have prolapse of the top of the vagina, where that kind of comes down as well, and it can come beyond the opening of the vagina too. So those are kind of the three main types of prolapse that we talk about. So what are the symptoms of prolapse? Well, prolapse, contrary to what some people may think, is not painful. So women do not complain of pelvic pain with prolapse. Now, certainly other things can happen together with prolapse that cause pain, but prolapse in and of itself just causes discomfort and pressure. So women often complain of a sensation of heaviness or pressure that happens commonly towards the end of the day, or if they've been exercising or doing a lot of activity that can make that pressure and heavy sensation worse. They might also describe some discomfort that happens in the lower abdomen, and this is, we think, because the pelvic organs kind of are being tugged on by the prolapse, and that causes that sensation in the lower abdomen. Now, once the prolapse becomes to a certain point, you can get a bulging sensation, usually outside of the vagina. So you can feel this inside the vagina, but most commonly this doesn't become really bothersome until the prolapse extends beyond the opening. And this is often a really disconcerting finding for women because all of a sudden they feel a lump or a mass, or they're worried it's a tumor that's in the vagina. Certainly sometimes your cervix can feel like a hard lump too, and if that's coming down, that can be a little unnerving. And the good news is, this is not cancer, it's not a tumor or anything like that. It's just what we just showed you in the pictures. It's your pelvic organs descending, and that's really what you're feeling. So you're feeling the vaginal wall, most likely, with either your bladder or the rectum behind it when you're feeling that bulge. And we talked about this already as well. You can have some urinary problems with prolapse related to the prolapse. So if you have a cystocele, so if the bladder is dropping, that tube we talked about, the urethra, can kind of get kinked off, and it can make it hard to empty your bladder. So sometimes women will complain of difficulty with starting voiding, so a weak stream, or the sensation that they're not able to empty completely when they do attempt to urinate. So those are some common urinary symptoms that could be related to prolapse. And then bowel problems certainly also are related, and sometimes these can be the cause of prolapse if you have chronic straining or constipation. With a rectocele also, sometimes you have the sensation that you can't get all of the stool out when you're having a bowel movement, and this can be because the stool is getting trapped in that pocket, kind of that I showed you in one of those earlier pictures. So the stool, instead of going straight down through the anal opening, can actually be diverted through that rectocele pocket, and so it can make it difficult for you to get stool out. So that's another symptom that you can have. The good news is we have lots of great treatments for prolapse, and we always like to talk about the conservative treatments first. So again, like I mentioned before, prolapse is not life-threatening, it's not a cancer, it's nothing that's really it's really a quality of life issue, and for that reason it's important to treat, but sometimes just being reassured that there's nothing really dangerous going on is important also. So the first kind of treatments, like I said, we talk about are conservative. The most conservative treatment is the watch and see approach, or expectant management, and this is kind of just to see what happens over time. So there is a small percentage of women in which prolapse symptoms actually improve. We don't know why that happens, but they are out there. But that's relatively uncommon. So if you have constipation, dietary changes can be helpful to manage that. We talked about pelvic floor muscle exercises and physical therapy, which are very important options to help get those pelvic floor muscles stronger. And if you have relatively mild prolapse, pelvic floor physical therapy can actually help improve your prolapse. So it's really a really valuable tool. And then there's pessaries. That's what that picture is on the right. The pessary has actually been around since the time of Cleopatra. Apparently she used a pomegranate as a pessary because she had prolapse. So prolapse has been around for as long as we've been having vaginal deliveries, and pessaries also have been around almost that long. So a pessary today's pessaries are made of silicone, not pomegranates, and they are usually a ring that's inserted into the vagina, similar to a tampon, so that you feel it when it goes in. But if it's the right size and it's the right fit, then once it's in place, you really should forget that it's there. And the benefit of the pessary is that for a lot of these, you as the patient can manage the pessary, so you can wear it as little or as often as you want. We have lots of women who just have symptoms with exercise or certain activities, and so they use the pessary just during those activities. And the pessary helps with the prolapse symptoms, and also there are some kinds of pessaries that you can see, actually all of these have a little knob, which help with leakage of urine as well. So the pessary is a great non-surgical option for management of prolapse. We do have some great surgical treatments as well. And again, this is tailored to your wants and desires after you talk to your physician and kind of decide what's right for you. Surgery is not right or necessary for everybody, but it is a really good option. And we have lots of different surgeries that are available. And of course, these surgeries are tailored to you and to your certain type of prolapse, to your certain medical conditions, your prior history of pelvic surgery or other abdominal surgeries, whether you want to maintain vaginal intercourse, the ability to have vaginal intercourse, and of course, there are surgeon-related factors as well. So really the goals of surgery are to restore normal anatomy and support. So we want to take, the prolapse tissue and restore it to what is normal, reduce the pressure and heaviness sensation from the prolapse, and really the ultimate goal is to improve your quality of life. So that is our goal with the surgeries that we do. And Dr. Schimpf mentioned this as well. We have surgeries that maybe we no longer do, or we have improved techniques of how we do them. So, if you have a family member who's had a surgery and didn't do well after that surgery in the past, I still encourage you to go, if you're having symptoms of prolapse and you're interested in your options, to go find a provider and talk to them about your options, including surgery, because that might be one of the best decisions that you make. And together, you and your doctor can decide what's best for you. So to summarize our portion of the talk, we just want to make sure that you're not alone. Pelvic floor disorders are really common. And the good news is we have great treatment options for urinary incontinence, for prolapse, that, hopefully if you're suffering from any of these things, you will take the initiative to go talk to one of us or another urogynecologist about this. So I am going to pass this along to Jen Schifford, and she's going to tell us about pelvic floor physical therapy.
Thanks, Carolyn. So just to touch base a little bit on the history of our pelvic floor program, the Physical Therapy Association, our national organization for women's health, has been around for over 35 years, so it's been around for quite a long time. Many people aren't aware that this is an area of physical therapy. And initially it started with a focus on treating women following their childbearing years with pelvic floor disorders postpartum. Over time, we began to treat women throughout the life cycle, and our emphasis as well, specializing on anatomy and function of the pelvic floor. That's our expertise. Care is also available to men with similar dysfunctions. We also have a pediatric program as well, so trying to catch these problems earlier on so they're less problematic as you age, and hopefully we can help you in resolving those issues. So our pelvic floor program here was established back in the fall of 1999, a long time ago in a galaxy far, far away. Common diagnoses referred, we see just about anything you can think of comes our way. We have quite a variety of departments that refer to us, urinary and fecal incontinence, patients that have difficulty with urination, constipation issues, prolapse, pelvic floor pain such as vulvodynia or vestibulitis, vaginal and rectal and pelvic pain, lower abdominal type pain, scar tissue, which could be after you've had your child, you may have a scar from episiotomy or childbirth, abdominal scars from cesareans. We see men post-prostatectomy. We also see patients after they've had oncology or a cancer history of the pelvic floor region, and radiation, which can traumatize the tissues. And we do have a program for that as well. Pre- and postnatal care, and pediatric pelvic floor dysfunction, and also gender confirmation surgery. We often treat many patients that have pain issues. Who refers to physical therapy? OBGYN, urogynecology, urology, GI, colorectal surgery. This is just to name a few. You can also be referred by a physician assistant, a nurse practitioner, your primary care. You just have to speak up and mention your issues that you're having. One of the hardest things is to talk about it with your physician, but the sooner you do, the quicker you can get to the proper care. So we've already kind of gone over the anatomy for the pelvic floor. And your pelvic floor musculature helps to support your pelvic organs and helps to keep things in place. They also help in the sphincter action, so those little circular muscles around the openings of the urethra and the anal area to help contain urine and bowel, and so we can eliminate when we choose to. Also aids in sexual response. Having good tone in your pelvic floor helps for sexual function. And stability. It also provides stability of our joints to our pelvis, including all the various bones in our pelvic area. And it assists the abdominal muscles in stabilizing your trunk as well with movement. So pelvic floor dysfunction, when the muscles are weak, the supporting structures or ligaments can become overstretched, and that can cause the bladder and bowel problems as well as pressure or pain in the pelvis, which we've already touched base on a little bit. So this is just a little bit of a review. And the symptoms we've gone over as well for pelvic organ prolapse. So if you feel something that's heavy that relieves by lying down, then that very well may be an issue that you're having. Also, you may have complaints of backache or difficulty with penetration with intercourse because something's in the way. Physical therapy can provide an assessment of your spine and your pelvic musculature. We look at the tone, we look at how you're coordinating your muscles. There is an evaluation looking at your muscle strength throughout your body. We do an internal assessment, pelvic exam, to see actually how well you can isolate your pelvic floor muscles and look at your strength and tone as well. We will also give you diaries if you're having bowel or bladder issues, just to get an idea of what's happening with your bladder during the week. How often are you urinating? When are you having incontinence? As well as with the bowel. We'll instruct you in appropriate exercises to help maximize your strength and flexibility and hopefully get you back to the things that you want to be doing and not let these issues limit you in your daily activities. And we'll provide hands-on treatment to improve your muscle tone. So if you're having tightness in the muscles, we'll work on hands-on release techniques to help reduce the muscle spasm so your muscles can function better. When your muscles are tight, they're also weak. We'll also provide a very individualized home program for each patient based on what we find in our examination. And we'll instruct you in the appropriate Kegel exercises, making sure, again, that you can isolate those muscles properly. And also going over the proper toileting postures, or what I like to call the proper poo-poo position. And basically everybody should know how to do this. So we're going to touch base on it because you're not walking away from this webinar without knowing the proper way to poop. So everybody that has, you can use a stool under your feet. You can, to help relax your muscles, if having your knees higher than the hips, which simulates a squatting position, actually helps to relax the muscles that sling around your rectum to kind of close it off when we don't want to poop. And so by bringing the knees above your hips, you relax those muscles, allowing for a straight shot for stool to come down. So if you're having trouble with pooping, positioning is really key. And also how you push, pushing gently out through your abdominal wall, not pulling your abdominals in. When we actually pull our abdominal muscles in, we're also going to tighten our pelvic floor. And so when we go to poop, we want to do the opposite. We want to breathe in, relax, exhale, and gently push outward. All right, there you go. No constipation out there. If you're having those issues, you know how to get a hold of us, or you will by the end. We use biofeedback to assess your pelvic floor muscles. That is something that is a little less invasive. We can use surface electrodes right around the anal area just to give you an idea. It connects you to our computer screen, and you'll see a line that goes up, or we can have a circle that closes when you contract your pelvic floor. And it just helps you to get an idea of how those muscles work and gives you a visual feedback. Many people like that visual cue as well. We also can help you learn how to relax your muscles. We'll also provide information on how to retrain your bladder and how to retrain your bowel if you're having urgency type issues. So another common treatment are Kegels. Again, we do more than just Kegels, but this is the basis of, you really need to understand the general concept of it, and you need to have that general idea of how to contract your pelvic floor properly. Then the history of it was named after Dr. Arnold Kegel, who invented the world's first biofeedback device to monitor pelvic floor muscles during a contraction. And they were first used as a method of controlling incontinence in women following childbirth. The principles are just to strengthen the muscles of the pelvic floor to improve that closure of the urethra and aid in that sphincter function. It helps the sphincter muscles, which help prevent leakage of urine or stool with coughing, sneezing, lifting, or other stressful movements that you might incur during exercise or daily activities. Other benefits of Kegels are to decrease or prevent the prolapse of pelvic organs. Kegels are one way to help reduce pelvic organ prolapse. We have other exercises as well called hypopressive exercises that use various postures and breathing techniques to help lift and improve the tone and quality of your musculature to better support your organs. So we can reduce the prolapse. Through research, it shows a good centimeter, and we can help patients become less symptomatic. It also helps to perform Kegels to enhance sexual function, good muscle tone, aids in our sexual function, and conditioning our muscles and having a better understanding of how they work can help make childbirth easier. To think about how to do a Kegel exercise, it is a tightening of the pelvic floor, it's a closure, it's a lift. We're thinking of lifting in an upward fashion, closing the urethra, closing the anal sphincter, like you don't want to pass urine or gas. It's a lift and squeeze or a vacuum type action, trying to stop the passage of gas or unwanted urine leakage, picking up a marble literally with your vagina. And for men, also thinking about pulling the penis inward, so we call it pulling, or pulling the turtle head in the shell. So literally pulling inward and not just lifting the anus. So you got to pull it all in, all right? So for locating the muscle, you can literally place a finger in the vagina or rectum and attempt to squeeze. That's the most literal way to do it. If you're not wanting to do it that way, you can also use a mirror and just hold it down there to look at your pelvic floor, and you want to see an upward lift towards the abdomen. When you're sitting and trying to do a Kegel, that's another way to help locate the muscles. You could sit on a rolled towel and try to feel the muscles lift up away from the towel. You shouldn't feel the outside muscles moving, like your outer butt muscles or your thigh muscles. Biofeedback, this is just a picture of what it may look like in the clinic. So on the right is the computer, which shows a line that's going up, is the red, which is contraction, and then down is blue. And so that's a relaxation phase. We may use an internal probe. We may use surface electrodes. So that just shows on the left a probe inserted in the vagina, which will read your muscle contractions when you squeeze around it. Other type treatments we have that we can send home with you are shown here. We have probes that are inserted internally, whether it's rectal or vaginal. The vaginal probe is that top one on the right, and the rectal probe is the bottom one. And it can attach to the device that you see there all the way top left, which is a home biofeedback device, and it shows a line that goes up and down. So when you contract, it goes up. When you relax, it goes down. We can also do electrical stimulation internally to help facilitate a muscle contraction if your muscles are weak. And this is just an example of a home electrical stim unit. So if you can't contract your muscles very well, this might be a good starting point for you to help you find those muscles and contract them better. Again, these are some pretty standardized treatments in physical therapy. Oh, let's go back one. All right. So another type of strengthening, you can use weights. There is a vaginal weight or a rectal weight that you can use that are just about a pound, which gives you really good weighted feedback and often helps patients really find their muscles. You do need to have a little bit of strength. You need to have a little bit of ability to contract your pelvic floor. You at least need to be able to squeeze around your finger. If you can, then we're ready to start a vaginal weight. You gain strength twice as fast with using a weight than you would just doing Kegels alone. So again, it is beyond Kegels when you're working with pelvic floor physical therapy. Rectal and vaginal weights don't have to be used with everyone if you're not comfortable with using one. But know that you can go beyond Kegels by adding some resistance and gain the strength twice as fast. Basically, for pelvic floor dysfunction, we want to prevent, we want to maintain a good level of fitness. So for you to continue doing the exercises instructed at home will help in maintaining what you've gained in PT and hopefully take you further. We try to get you back to the things you want to do. I don't want you to be the person in the back of an aerobics class that won't do any kind of jumping type exercises because you're having leakage. We help you to learn and recruit the pelvic floor muscles, and we want you to exercise those muscles often. Following the instructed home program given to you by your physical therapist will help to optimize your control. The treatment plan, if we see you for weakness, you might see us for 2 or 4 visits a month over 4 to 8 weeks, and it may vary depending on what we find in your evaluation. For pain, we'll probably see you a little bit more often, possibly 1, maybe 2 times per week for a longer duration. How to locate a pelvic floor physical therapist in your area. This is a national website, the womenshealthapta.org. And if you go to that website and click on Locate a PT and then put in your state and your zip code, it'll locate a PT for you nearest you. These are the locations for Michigan Medicine. I work with a wonderful team of pelvic floor physical therapists, and we have currently 4 locations. Eventually we'll be expanding to the Brighton Health Center. Look forward to hopefully seeing some of you. Thank you.
Okay, wonderful. Thank you, guys. We're going to go ahead and jump right into our Q&A session. We're already getting some fantastic questions from our participants. So we're going to change the camera view really quick here. All right, and these are our wonderful providers. So the first question that came in is, how is prolapse diagnosed?
So prolapse is I'm Dr. Swenson, by the way. Prolapse is diagnosed on clinical exam. So if you were to come see one of us, we would take a history from you, get a history of your symptoms, of course, your prolapse symptoms, urinary symptoms, general medical history. And then on exam, we do a certain type of pelvic exam where we take measurements to look at your pelvic support. So that exam is called the Pelvic Organ Prolapse Quantification System, if you need to know the name of it. And what we're looking at, those 3 compartments that I told you about, so we take measurements of the anterior wall, the top of the vagina or the uterus, and the back wall of the vagina, all in relation to the opening of the vagina. So that's kind of the general idea of how we would assess the pelvic floor. And then the prolapse is staged. So there are prolapse stages 0 through 4, and I wouldn't worry too much about what makes the different stages. 0 is perfect pelvic support, and stage 4 is complete prolapse. And the other stuff is probably, it's in between there. But that's the gist.
So just a reminder to our participants, you can use that Q&A button on the right side of your screen and go ahead and type in your questions. The next question we have is, how should someone decide what kind of doctor to see?
I'll take that one. So, hi, I'm Dr. Schimpf. So there are a lot of good doctors that take care of this. We work here at Michigan very closely with our colleagues in urology. They take care of a lot of urinary problems as well. So sometimes you're certainly, please do call us and schedule an appointment if you'd like. Sometimes the best person to help you with that decision is your primary doctor or your established gynecologist, if you have one of those that you're seeing regularly. I think certainly if you're having bowel incontinence or a problem after your delivery, we have fantastic clinics for those in our department here in OBGYN. And then beyond that, sometimes if you call us and just start somewhere, we certainly send patients back and forth with the urologist here at Michigan. If you're having more vaginal symptoms, it's probably best to see a gynecologist. If you're having more bladder symptoms, sometimes urology is the way to go.
Another question that came in was, my daughter was diagnosed with PFD due to symptoms that she is having that are similar to a UTI, but she does not have a UTI. They said it was due to stress. She's 18, active and healthy weight. Do you see patients with PFD due to stress?
My name's Dan Morgan again, and thanks for the question. I think all see patients who have reasons for symptoms developing that may not seem completely obvious. So I think, just as Dr. Schimpf was saying, yes, we often do have patients who have symptoms that are maybe not entirely related to an anatomic problem, and they can be related to stress, and often we can help quite a bit by just identifying different stresses and triggers, and we'd be happy to see those types of patients.
Okay, here is another question. Is there such a thing as too many Kegels? I had a 3rd-degree tear and completed PT after I had my baby. However, now I feel like I've done so many that sex can sometimes be uncomfortable at first.
So that's a great question. Yes, actually, if you're having pain with performing Kegels or Kegel exercises, then you should actually have your doctor refer you to physical therapy. Your muscles actually could be tight. You could have some spasm that might need to be worked on by a pelvic floor physical therapist, and then gradually reintroduce strengthening. There also could be issues if you had any scar tissue as well, and that can be contributing to pain. So it's always good, we always try to address the pain first before we do the actual strengthening component. So I always like to say we lengthen the muscles before we strengthen to get them back to their optimal resting tone. So it shouldn't hurt to perform a Kegel.
Do you treat, not say this correctly, do you treat the diastasis?
Diastasis, yeah.
And bladder prolapse together?
So yes, we do look at your abdominal wall, and we do check for diastases with all of our patients. And we'll often find that there is still a separation, and there are various ways that we can treat that through exercise and through manual techniques. It is important to have stability in your abdominal wall as well. And you have to remember our muscles work together in our core, and by doing that, that's going to give you the best support as well for that prolapse. So we do look at both. We do treat both.
Okay, the next question is a follow-up to the PFD to distress question. Should this person see a doctor or a physical therapist?
I think, so I'll follow up with that since I started. I think that often it will involve multiple practitioners. It might to help get the best response. So I think if you have somebody who you're seeing already for primary care, I think that they can hopefully make a good recommendation to you to where to start. And then often if you see one of us, we may help to get some people involved, such as Jen and other physical therapists that can be helpful.
Okay, let me just make sure I'm staying up with these questions here. So what can a patient expect at a doctor's appointment, at an initial doctor's appointment?
So at the initial doctor's appointment, often we've mailed you some paperwork in the mail, and we'll have you bring that in. We'll go through that. We'll have some extra questionnaires about urinary symptoms and maybe some of the other problems that you're having that we'll have you fill out. And those help us get some objective measures of what's going on. We'll also have you talk with us about, just simply put, what's bothering you, what's bringing you here, what kind of treatments have you had before that haven't worked. By the way, if you've had surgery or extensive treatments somewhere else, it's really helpful if you can bring those records in with you. That can save some time sometimes. So we'll go through that very detailed history, talking about all these different things. So even if you're just here to talk about urinary symptoms, we're still going to ask you about bulges, bladder problems, bowel problems, sexual functioning problems, just to kind of get the whole rounded picture. And then, like Dr. Swenson was talking a little bit earlier, we're going to do a pelvic exam. A lot of people say it's the most detailed pelvic exam they've ever had. And we'll talk in some numbers, and we'll look at various different things, starting at the outside, working our way into the different parts of the vagina, maybe at the uterus if you still have a uterus, and doing a very detailed pelvic exam, including feeling the organs on the inside. Sometimes we need to do rectal exams as well. Some patients need ultrasounds of maybe the anal sphincter muscles, and we can perform those in our clinic as well. Most of us will get a urine sample depending on why you're at the office. Sometimes we do a catheterization to see if the bladder is emptying completely. And then we're going to talk through everything we've learned about you and where we think you need to go next. And that's a two-way discussion. That's a discussion of, here's kind of what we're thinking, maybe here's a list of options, what sounds good to you, and then together we can make a plan for how to move forward. As you've probably picked up along the way, sometimes that means surgery, but oftentimes it means maybe just watchful waiting, maybe thinking about physical therapy or other non-surgical options. We can do the full range, and many times that decision is in your hands.
Thank you. And if a patient does have surgery, how long will it last?
I can answer that one. So it depends on what surgery you have. So we talked about this before, but the surgery, the type of surgery you have is going to depend on your own medical and surgical history, the type of prolapse that you have. And so it's going to depend on a couple of things. And sometimes we do surgery that involves a hysterectomy, but sometimes our surgeries don't need to involve a hysterectomy or taking your uterus out. So those kind of things can affect the length of surgery. So your surgery could last anywhere from 45 minutes to 4 hours, depending on what it is that we're doing. So there's wide variation. There's not one surgery for everybody. Dr. Morgan mentioned the surgery for stress incontinence, the tension-free vaginal tape. I mean, that takes about an hour, so that's one of the shortest surgeries that we have. If we do a hysterectomy and other prolapse repairs through the vagina, that can take about three hours. And then we have laparoscopic or other minimally invasive approaches to fix prolapse, and that can take about 3.5 hours as well. For most of our surgeries, they're done either as an outpatient, so you go home the same day, or you stay one night in the hospital. So most of what we do is vaginal surgery and laparoscopic surgery, so it's all minimally invasive, so done through tiny incisions in the abdomen or done vaginally. Every once in a while, we do make a bigger incision on the abdomen. That's called a laparotomy, but that is pretty uncommon. So the nice thing about minimally invasive surgery is patients recover really well and usually don't have to take a whole lot of pain medicines after surgery, too.
Thank you. Okay, so that we're respectful of time, we'll go ahead and ask this one last question. Are there specific shapes or weight recommendations for Kegels, and where can we buy them?
So there are numerous things when you look on the internet for getting weights and getting different kinds of Kegel devices. You really can't go wrong in anything that's trying to help you find your pelvic floor and strengthen your pelvic floor. I tend to like the weights that are heavier, to give you more of that weighted feedback and to do a little bit more rigorous strengthening, because I find that patients with stress incontinence really have great success to the point where they can exercise and not have any leakage. And so I tend to like the weights that are heavier. You can go online and you can go through the Best for Life website to find vaginal or rectal weights, and that's an excellent choice. There are other weights as well that are step-free weights that you can walk around with that just work on that tone and ability to hold something in. Those are good as well, and those would be my recommendations.
Thank you. So that actually answers all of the questions that came in. And that will conclude this evening's presentation. So I want to thank all of our participants for being with us this evening, and I'd also like to thank our wonderful presenters for sharing their expertise with us. Participants, if you have additional questions or if we didn't get to your question, please feel free to email it to umhs-whrc@med.umich.edu, and that email address is listed on the PowerPoint presentation that we'll be sending out. In addition, please look for that email, and that will include a recording of the webinar and a link to a survey. We do greatly appreciate your feedback. Thank you all very much.
Thank you.
Thank you.